Hello, and welcome to this podcast, which is brought to you by Clinical Education Alliance. I'm your host, Shara Pantry. Today's episode features experts Dr. Manali Bhave, medical oncologist at Emory University, clinical pharmacist Annalise Labatut, also from Emory University, and nurse practitioner Jamie Carroll from the Mayo Clinic. Today, our experts will be discussing their experiences with oral SERDs for the treatment of hormone receptor positive, HER2 negative metastatic breast cancer. Topics covered today include an overview of clinical trials with oral SERDs, including the EMERALD study that led to the FDA approval of elacestrant, potential adverse events with oral SERDs and how to manage them, and ways to promote treatment adherence and persistence. This episode is part of a larger educational program titled Ensuring Optimal Clinical Benefit from Oral SERD Therapy in Patients with HR-Positive, HER2-Negative Breast Cancer. For more information on our expert panel, along with a link to the larger educational program, please visit the show notes for this episode. Now, let's get started and hear what the experts have to say about this important topic.
All right. Welcome to our conversation today on oral SERDs. My name is Dr. Manali Bhave, and I'm a breast medical oncologist and director of the Phase 1 Clinical Trials Unit at Emory University in Atlanta. And I'm joined by my colleagues, pharmacist Annalise Labatut and nurse practitioner Jamie Carroll, who I will have further introduce themselves. Annalise?
Hi, thank you. My name is Annalise Labatut. I'm a clinical pharmacist at Emory Winship's Breast Cancer Clinic, the Blinn Family Breast Center. I work with Dr. Bhave as well as all of our other breast providers. I've been working there for about 2 years now.
Thank you, Annalise. And Jamie?
Welcome, everybody. My name is Jamie Carroll. I'm a nurse practitioner here at Mayo Clinic in Rochester, Minnesota. I work in the breast group. I'm assistant professor in medical oncology here, and I've been at Mayo for 9 years. Welcome.
Thank you, Jamie. Today's discussion will really be a conversation on oral SERDs, including elacestrant and several other SERDs that are still in clinical trial. We'll also do, as part of that, a brief overview of the oral SERDs and then end really with a discussion and conversation about our clinical use of these oral SERDs and how we practice, how we promote adherence, what kind of adverse events we're seeing, et cetera. So we have 2 positive studies thus far, including the EMERALD study, which investigated elacestrant versus fulvestrant, and the SERENA-2 study, which investigated camizestrant versus fulvestrant. EMBER is an ongoing study of imlunestrant as monotherapy and in combination with other targeted therapies such as PIK3 inhibitors, mTOR inhibitors, and CDK4/6 inhibitors. We have seen some promising early phase 1 results with imlunestrant and are waiting phase 3 data. There are also a number of ongoing combination studies with oral SERDs, including camizestrant and giredestrant as well. So the EMERALD study is led to the FDA approval of elacestrant, and after that approval, elacestrant becomes standard of care. In the study, it investigated elacestrant versus standard of care endocrine therapy for patients with advanced hormone-positive HER2-negative metastatic breast cancer after progression on 1 to 2 lines of endocrine therapy, including 1 line of a CDK4/6 inhibitor and up to 1 line of chemotherapy, although the majority of patients had not seen chemotherapy prior to enrollment. In that study, patients were randomized to elacestrant 400 milligrams daily versus standard of care endocrine therapy. And the primary endpoint was looking at progression-free survival in all comers, so the intention to treat population, as well as those with specifically ESR1 mutations. As mentioned, EMERALD was a positive study with a statistically significant improvement in progression-free survival, particularly in those patients that harbored an ESR1 mutation. And that PFS across all comers with an ESR1 mutation was 4 months compared to 2 months with standard of care endocrine therapy. It's really important to note, though, that when we did a further subgroup analysis to tease out patients that were endocrine sensitive and therefore had a prolonged response to elacestrant, we found that patients who had received a CDK4/6 inhibitor for at least 12 months had a progression-free survival of 8 months, so very clinically significant compared to standard of care endocrine therapy alone. That requirement for prior exposure to CDK4/6 inhibitor and in terms of length of response to CDK4/6 inhibitor is not required for patients to receive elacestrant, although again, I think a very clinically useful marker of response to elacestrant. Elacestrant was approved in January of 2023 for patients with hormone-positive, HER2-negative metastatic breast cancer who have an ESR1 mutation. and have progressed on at least one line of endocrine therapy. It's important to note the adverse event profiles of all of these drugs as well. And in general, I would say all of the SERDs are well tolerated. With elacestrant, the most common adverse events that we were seeing were nausea, fatigue, vomiting, potentially arthralgias. Specific to two of our oral SERDs, we do see some low-grade visual disturbances in bradycardia with camizestrant, which is important to note, as well as sinus bradycardia with giredestrant. Imlunestrant, we have not seen those same visual disturbances or cardiac toxicities. However, we do see a higher rate of low-grade diarrhea, nausea, fatigue, and neutropenia with imlunestrant. So now I want to actually bring in my colleagues to ask about their experience with oral SERDs in the clinic. So let's start with elacestrant. And Jamie, maybe I'll start with you. How often are you using elacestrant in the clinic, and what are some of the common adverse events that you're seeing, and how are you managing those?
I think recently we've had more of our oncology team start to look for ESR1 mutations earlier to assess for would we do an early switch to elacestrant, or would we look for those ESR1 mutations and then see at how long it takes for a patient to progress on their CDK4/6 to when we would need elacestrant. I think in general, like you mentioned in the AEs, our patients are tolerating elacestrant fairly well. So when we do make that switch, they're tolerating that monotherapy well.
Great. And Annalise, I know that in our clinics, you follow a lot of our patients that are on oral therapies, including elacestrant. What are some of the common adverse events that you've been seeing, and how have you helped patients, particularly with side effects like nausea?
I would say I will echo with what Jamie was saying, is I am seeing it more since its approval, that we are using it more in testing for ESR1 mutations sooner. The most common adverse event that I see is most likely nausea, followed by fatigue. For nausea, I was refreshing myself earlier, and NCCN does classify elacestrant as a moderate to high risk for an oral anti-cancer treatment, meaning about 30% of people experience emesis. The initial recommendation is to initially manage with PRN treatment, and that reflects what we do in practice as well. I would recommend sending PRN antiemetics from two different classes, like a serotonin receptor antagonist, as well as a phenothiazine, such as prochlorperazine, so that patients can utilize both of those or alternate them should they need to. Another tip that I've found works really well for patients who are experiencing nausea is to take an antiemetic 30 minutes to an hour before their dose of elacestrant, because I found that they are generally getting nauseous maybe right after they take it. And I know this is on the agenda to talk about later. I think it's potentially because it is a very large pill as well.
Yeah, absolutely. And I think it's really important to emphasize taking it with food too, which can sometimes help that nausea. And how about symptoms like more of on the endocrine therapy side of it with hot flashes or arthralgia? Have you been seeing a lot of that, Jamie, in clinic, and how have you been managing those side effects?
We do see the arthralgias, but I think the hot flashes actually get better on the elacestrant than they do with the aromatase inhibitors.
Yeah, I actually agree with that. I have felt like nausea and fatigue have been the primary side effects, and then significantly less hot flashes or arthralgias compared to the AIs that patients had been on previously. And wanted to jump to some of the other oral SERDs as well. And I know that a lot of these we've seen as part of clinical trials, and so we don't have phase 3 data on adverse events. But with, for example, imlunestrant or camizestrant, what are some of the adverse events that you guys have been seeing in patients on those clinical trials?
Yeah, so I do have a clinical trial open that does utilize imlunestrant. So I do have some experience there, do have some nausea, some fatigue with imlunestrant, but overall patients tell me that they tolerate it similarly from the aromatase inhibitor that they would have been on prior to switching to the imlunestrant. I had 2 patients that interestingly had foot pain that did improve after being on the imlunestrant for a few months.
Yeah, I agree with that. So we also similarly had the EMBER study open, the phase 1 EMBER study with imlunestrant, and I would say in general very well tolerated. We did see some diarrhea. It was mostly grade 1 or grade 2 diarrhea. So patients were using, Imodium as needed, or in one patient, I did have to escalate slightly to Lomotil, but in general, low grade GI toxicities. And how about lab abnormalities? So we are checking labs on these patients potentially on trial more frequently than standard of care elacestrant, but at least once a month. What kind of lab abnormalities are you seeing particularly any LFT changes, or are you guys tracking cholesterol levels, et cetera?
Yeah, so I have not seen any LFT abnormalities in my patients on imlunestrant. I realize that the number of patients on 50% get imlunestrant, 50% stay on their current endocrine therapy. So my N number is not super high, but I have seen some cholesterol changes. Of the half the patients that have gotten the imlunestrant, a couple of them have already been on cholesterol medications. And so of those patients, there is interactions between some of the cholesterol medications. So they've already had to change their cholesterol medications to stay on the imlunestrant. So I know that there are some contraindications there, but I've not seen any increase in the cholesterol levels with patients that have been on imlunestrant.
That's great. So in the study with Emerald, we saw that the incidence of having a higher cholesterol or higher triglyceride level was close to about 25 to 30%. And there were some incidences of grade 3 and grade 4, although less than 5% in regards to hyperlipidemia. I'm essentially checking it at baseline, and then intermittently, I might check it every couple of months. But I agree with you. I haven't seen any major changes yet to cholesterol levels. Annalise, have you, because I know you've been kind of monitoring that in our clinics as well.
I agree. I've been recommending a baseline and then at least every 3 months. And clinically, especially when comparing to the percent that was reported out in the trial, I'm not seeing the same levels of increased cholesterol with elacestrant that I would have maybe expected to see.
And I know that, Jamie, you briefly touched on this too. So we know that elacestrant is metabolized through the CYP3A4 pathway. And so we really are trying to educate our patients on avoiding CYP3A inhibitors and inducers. How do you educate your patients on this in clinic? It's kind of a tough concept for patients to grasp. And I know Annalise does a lot of our teaching as well for oral therapies. But for you, Jamie, in clinic, what is the process to educate your patients on drug and then potentially avoiding those CYP3A inhibitors and inducers?
Basically, we tell our patients that if you're going to start any new treatments or any new drugs, just to let us know, because I think that it ends up alphabet soup for them where we're talking about pathways. And if somebody doesn't have a medical background, then it gets too confusing. And so we just instruct them, if you're going to start something new, if you see your primary care provider and they're recommending a new therapy, just to let us know and reach out so that we can talk to our clinical pharmacist and they can look at all of your medications so that we can be safe moving forward.
For sure. And Annalise, are there any common drugs that patients and providers should be aware of when they're about to start elacestrant?
Of course, always looking at antidepressants. Bupropion is a very common one that can affect the pathway, but something that comes up more commonly and something that I always try to ask patients is about herbal products and supplements, just because almost all of them are involved in the CYP3A4 pathway to some extent, largely and most commonly inhibition. So that's increased plasma levels, increased side effects, potentially increased LFT abnormalities as well.
Yeah, absolutely. I think the herbal supplements is a very good point. And I do strongly encourage our patients to, if they're starting any new medications, any herbal supplements, to come to us prior to starting that. Herbal supplements is always a tough conversation because I think a lot of patients want to supplement their standard of care therapies with natural approaches. And we want to encourage that, but at the same time, have to be very careful with how these drugs are metabolized. So really great points.
It's always our best to try to do it safely, to address patients' complementary needs and to integrate that, but to also make sure that we're not affecting the efficacy of the treatment or potentially increasing side effects. And as long as it's just encouraging them to tell us if there's a contraindicated herbal product or even medication that they are not willing to stop, I would rather know about it. So I wouldn't just dose reduce them because of these adverse events. I would really, again, encourage that cessation or holding that supplement.
For sure. That's a really good point. I wanted to switch gears now to, I think, another important topic, especially as we have new oral therapies that are coming into the market and are now part of our treatment paradigms. And that has to do with adherence and persistence to oral therapies. And I think that's a very challenging thing to discuss with patients and to ensure that they are being adherent to their daily or even BID dosing. I think it's often humbling to have that initial conversation with a patient when they have either a de novo or recurrent metastatic diagnosis, and really to explain that the intent of therapy is palliative. And one thing I try to explain is that our primary goal is to start these treatments to hopefully make patients feel better, with a secondary and also equally important goal of prolonging their life to the best of our ability. And oftentimes that conversation is, this is a marathon that we're running together, and we're trying to have as many treatment options available as we run this marathon. But this means that they will be on some treatment lifelong. And that is sometimes a shocking realization to patients, that they have to be on some form of treatment, whether it's oral or IV, every day of their life moving forward. How do you educate patients at the start of new therapies? Jamie, I'll start with you. And maybe at Mayo, what kind of workflow do you have in process as you initiate these new treatments in terms of chemo education and who they're meeting and who's following up with patients on oral therapies?
Yeah, so I think it's really important that we utilize our entire multidisciplinary team. We have our clinical pharmacist, I have clinical nurses, I have research nurses, I have my MD colleagues. So I just think it's important that our patients they're at the center of this care team, and that they have all the care members at their fingertips, so that we can make sure that they have the education that they need at their education level. We have patient navigators too. I want to make sure that our patients get what they need from us. So when we're discussing a new therapy, I make sure that if it's something that needs to go through the specialty pharmacy, that I've talked to my clinical nurse. She goes in and meets the patient so that there's that warm handoff. My clinical pharmacist will reach out to the patient in a couple of weeks, see if they got their drug, see how they're tolerating things, see what questions they have. So there's multiple touch points along that continuum. And that's especially important for adherence, because if we prescribe a drug and say, I'll see you in a month or I'll see you in 3 months, then our patients are likely to get confused or not follow up. And then if they don't have the appropriate contacts, phone numbers, then I think there's a risk that adherence decreases because the patients don't have that touch point in clinic. So they aren't going to be sure on what to do with their drug, when to take their drug. And if they start taking it and they have side effects, they're more likely to stop versus reach out to us because they just don't have the resources.
Absolutely. I completely agree with that. I feel like multiple touch points, having a multidisciplinary team involved in follow-up is really, really important. And Annalise, I know that at Emory, we don't have necessarily a set workflow, but a lot of us utilize a same process for initiation of new drugs. And that's typically that we have our MD or nurse practitioner make that decision with the patient about switching treatment, and then having that initial conversation and education with the patient about schedule of treatment and then potential side effects. Followed by that, we often have some additional teaching. And Annalise, as part of that initial teaching, what are you discussing with patients?
And I do my best to set expectations for them of what it's going to look like. And I always like to set those expectations of that it is different for everybody. And that's why the more you keep that line of communication open with us, the more we can tailor this treatment to you. There's no one size fits all. There's standard of care, but that may mean a dose reduction. That may be adding on supportive care medications, or they may be consulting palliative care for pain management or integrative oncology. I just, again, encourage them that it's going to look different for everybody, but as long as we know, it's our goal to make this as manageable as possible so they can live their lives as normally as possible. And just the conversation that we can manage this a lot of times like a chronic disease instead of something that can be more like abysmal or shocking to the patient.
Yeah, for sure. I also think it's important that when we're educating patients that they're receiving information in different modalities as well. So oftentimes we're giving verbal education, but then we're also handing them an information sheet, or I'm providing them with the website on where they can get direct information from sponsor of the drug that's patient focused as well. So I think reiterating that those points of schedule, potential adverse effects, when to reach out to us are really important, and doing that on multiple occasions and in different ways is helpful. Annalise, you mentioned pill size, and then also, if a patient is having adverse events, to reach out. How do you educate patients if they say, this pill is too big? What do you tell patients at that point?
I think it comes up so much more than I thought it would, especially with elacestrant. The 345 milligram tablet is 19 millimeters, which is just about 3/4 of an inch. It's pretty large. And first I asked them what they've tried. We wouldn't advise crushing these medications. There's no information available on that or how it affects the pharmacokinetics. But first I asked them what they've tried. They can take these medications in a spoonful of applesauce yogurt pudding to lubricate the throat, to lubricate the pill. And I find that does tend to work well, but I have run into situations where it hasn't. We had an older patient who was just not able to do that, and she started sucking on the pills to make them smaller, which we would not advise. So instead, what we ended up doing was ordering the 86 milligram tablet, which is much smaller. It's 9 millimeters, and gave her 4 of them, which is 344 milligrams. So we were able to circumvent a dose reduction and make the medication able for her to be able to take it as well and tolerate it better. But that's something that has come up time to time, especially with this pill, capecitabine, as well as on the larger side.
Those are really good points. Are there any adverse events in which you would tell the patient, if you have those, please stop your medication and call us right away? Jamie or Annalise?
For me, things that I would recommend: diarrhea not well controlled by Imodium, vomiting for greater than 24 hours, shortness of breath on rest, anything that is concerning or that they should seek urgent care for.
Absolutely. And how do you discuss, Jamie, potentially reducing the dose? So I think a lot of patients have hesitation when we say, you know what, I feel like your symptoms are escalating. It's time for a dose reduction, or your liver enzymes are up, which is sometimes a tough thing for patients when the labs are off, but the patients feel well about the necessity for dose reduction. How do you discuss that with the patient in terms of why it's needed and how it may or may not affect efficacy?
Yeah, so I usually try to tell the patient we're trying to find the right dose for you. Sometimes I go the safe route if it's an LFT abnormality, because you're right. Sometimes if it's something that we're worried about, but the patient can't feel those side effects, certainly if it's something like diarrhea, they can feel it. But if it's something like LFT abnormalities, or in some cases, not in this case, but if it's neutropenia, for instance, they can't feel that change, then you have to try to go what's the safest route. But I try to say, we're just trying to find the right dose for you. And then I say, we want you to be on therapy as long as we can. And so if we are needing to do holds, then you're off of therapy more than you're on therapy. So if we can find the right dose for you, even if it's a dose reduction, then we can be on therapy longer than we're off of therapy. So I try to go that route. And usually that gets through to the patient that we're just trying to find the right dose for them the safest way we can.
Absolutely. I think that's a really great point. And I agree with you. I think if we frame it in terms of we want it to be safe, tolerable, and we want to utilize it for as long as possible before having to make that switch, I agree that most patients feel more comfortable with that dose reduction or dose hold prior to resuming treatment. I wanted to end a little bit with access to some of these medications, and specifically with elacestrant, and as we get approvals of some of the other oral SERDs, likely in the next year or two, how we ensure that we're getting appropriate access and what resources we have to ensure that patients are getting their medications in an appropriate time and it's being approved by their insurance companies. Have you had any delays in starting, for example, elacestrant in the clinic, or do you have any paperwork that you utilize to get insurance to approve the drug? Annalise, I think this has come up for us a lot, specific to elacestrant, because we don't have the other oral SERDs approved yet, but we've had some delays in insurance approval. And how have you handled that situation?
So it's really, I would say, all but resolved at this time. Every once in a while, there's a one-off. But when the drug was first approved, I would say it would take 4 to 6 weeks to get the medication approved and potentially pursue financial assistance for the patient if it was an unreasonable copay, which oftentimes it was. If denied, we write an appeal from our office, a letter of medical necessity, but then we still run into the issue of copay often. But elacestrant does have a patient assistance program, and we have medication assistance coordinators who work at our internal specialty pharmacy who fill out that paperwork with the patients, and I help coordinate that process with them as well. But looking at their income, their W-2s, and financial information to see if they're eligible for that.
I think that's also an important point, is that there are resources to get patients access to these drugs. So, when initially we were running into some delays, we had also kind of templated a letter with the Emerald result to appeal insurance companies if it was denied. Now we're seeing less of that, but also important to note that you can reach out to your either on the commercial end at the sponsors, pharmaceutical companies, or your MSL, and say, hey, I'm having a problem getting access to this drug. Where can we get some financial assistance, or how do we get this patient the appropriate drug? So there are a lot of resources, and I thank you both for your time and for a great conversation today on oral SERDs. We're certainly fortunate to be in a time where we have so many oral options for our patients, and we can really kick the can down the road in terms of IV and more toxic treatments. We have elacestrant that's approved, as we had talked about today in detail, and a number of great oral SERDs in the pipeline that will see results as both monotherapy and in combination strategies as well for patients that have hormone-positive HER2-negative metastatic breast cancer. So thank you so much, both of you, and we appreciate the audience for joining us today.
Thank you so much. Have a great day.
Thank you, Dr. Bhave, Annalise, and Jamie. And many thanks to you, our listeners, for joining us today. As a reminder, to view the full program, Ensuring Optimal Clinical Benefit from Oral SERD Therapy in Patients with HR-Positive HER2-Negative Breast Cancer, or to claim credit for this activity, please click the link in the show notes. And be sure to check back regularly for more episodes on important oncology topics.